When you need medical help fast, use NHS 111 online to go from home to an urgent treatment centre.
Mr. Williams, please come through.
Or a pharmacy.
Hello, the pharmacist will see you now.
Or if needed, stay where you are and get a call from a nurse, doctor, or paramedic. Get assessed and directed to the right place for you in as little as 90 seconds. Use NHS 111 online.
This is our People podcast, telling the stories behind South Tyneside and Sunderland NHS Foundation Trust.
Hello, I'm Fiona Thompson. I'm our Media and PR Manager for South Tyneside and Sunderland NHS Foundation Trust, and today I am joined by Mr. Chris Steele, who is our consultant optometrist and also head of our optometry service at Sunderland Eye Infirmary. And this is all with a view to talking about our new hospital, but we're going to be looking at each service to find out a little bit more about what it does. So Chris, do you want to kick us off with telling us a little bit about the background to your career?
Yeah, thanks. So I first became interested in eyes or eyeballs when I was about 15, probably because that's when I realised I needed glasses and went to the optician for the first time, and that's what sparked my interest in being an optometrist. So having done my A-levels, I then went to university in London, at City University, and studied for a degree in optometry and vision science. And then that led me to doing my pre-registration year in a hospital. And that, at the time, was quite unusual. Most optometrists in those days went into private practice, but people know as that Specsavers and high street optometry practice. So that was a different step for me, and the reason I think why I did that was during my second year at university, I spent a summer working in a private practice in the City of London, and I used to get quite fascinated by all these patients being sent off to Moorfields with various eye conditions, and I wanted to know why, what was happening to them when they got there, why they were being treated in a particular way, and that's what sparked my medical interest in optometry. So I decided that I wanted to pursue a career that would allow me to pursue a more clinical orientation rather than, at the time, a more commercial background. So, having done a pre-reg in the hospital, which was down on the sunny south coast in Hastings, which was then called the Royal East Sussex Hospital, and now the Conquest, I moved on to back to the university for a while and worked as a research assistant and worked at Moorfields Eye Hospital with the Institute of Ophthalmology and was involved in some epidemiological eye survey work looking at causes of glaucoma in African Caribbeans at the time. And then moving on from there, I went down to Eastbourne, went back to the sunny coast and worked in the Eastbourne District General. And then during that time, I had a couple of opportunities to work abroad, and I worked in Kenya, providing rural clinics for eye care in Kenya, which was a real experience, being flown around in a small light aircraft across tops of volcanoes and landing in the middle of nowhere. In sort of red soiled airstrips, was a real experience, and again that sparked my interest in the clinical side, where I was often being asked about eye conditions which I had no clue about at the time. I was very green-sticked and fresh to the profession, and that I thought I needed to learn more about these things, and if I ever went back, that's what I'd have to learn about.
So could you in theory do a medical degree and then specialise in eyes, or was it just an option to you from the very start that you
optometry
able to do that?
Is a profession in its own right. To become an optometrist, you do your degree and then you do your pre-registration year, which then qualifies you to work. If you pass all your exams, you become qualified as a General Optical Counsel. Whereas if you're a doctor, specialising in sort of medical and surgical treatment of eye conditions, then that's a pathway that requires medical school first. So, but I'll come on to more of the different roles later on, because that's quite interesting how things have developed here at Sunderland over the last 30 years, and it is almost 30 years to the day since I started working.
Oh, well, happy NHS birthday to you. Very good. Very good.
So,
and so your career's already taken you far and wide and across the world then?
yes, so in the last 30 years I've been very fortunate to have gone to various conferences. In the early days when we were going to Seattle, we even got to Australia with a couple of consultants who are still here just. One's about to retire and one's moving on. So they were happy days. And so there's always been lots of opportunity in the past to travel. But I think that it's the clinical work that has kept me here and the challenges that that's brought.
Yeah, and I'll just interject to say that I think we've already been rudely interrupted by the hospital's heating system. And for context, we're in a clinical room, but we're both wearing scarves despite the fact that it's spring, which will come on to why we're building a new hospital later on. But you said that your interest was sparked by the fact that you just went to get your eyes tested. So
yes.
What was it about that really drew you in?
I think at the time I didn't realise that doing your homework and things at the weekend, thinking it was just normal to have blurry vision, and I didn't really think that it was normal that you could see a television screen clearly. And then suddenly being given a pair of glasses, because I was just a bit short-sighted, the realisation that, crikey, you can see leaves on trees and you can actually see people's faces on the television was quite a revelation. So at the time I thought this is something I could really become interested in. It was always that, or thinking about pursuing medicine, but I think at the time the optometry degree was the thing that seemed to spark the interest more.
Very good. And so what does optometry involve, and within that, what do you as a consultant do?
Okay, well, optometry is it's a term that not everyone's familiar with. Or you talk about being an optometrist, some people say it's just somebody who looks on the bright side of things, but most people think of optometrists in terms of being an optician. So it's very confusing in eye work, because there's lots of different professionals all with similar roles. So as I mentioned, we've got the ophthalmologists, who are the medical doctors who specialise in surgery and medical treatments, and then we've got orthoptists who specialise in eye movements, and particularly with children but also adults, and optometrists who in practice are involved in detecting defects of sight, for example short sight, long sight, whether you need reading glasses. But they also look after people with various eye problems, and they're sort of place you come to for advice about general health problems as well. Because
sometimes you can spot other
That's
kind
right.
of medical conditions through the eyes as well, which is fascinating. But I guess that gives you a huge responsibility.
Yes. So optometry, the skills that you have as an optometrist are quite unique in that you have certain things that no other professionals, bar some doctors, where you can test eyes for glasses, with various ways of doing that, without even asking a patient, what letters they can see. You can determine what prescription they require by using certain techniques, which is fantastic when you're dealing with children. So the big thing is that in hospital work, the type of work that we're doing is far more specialised than what you do in practice. So in practice, you might expect going to see your optician, having an routine eye test for glasses, or contact lenses that you might want just for cosmetic reasons. Whereas here in the hospital, the type of work that we're involved in, our core service, is for refractions for patients who are having ongoing treatment. They might have had eye surgery, corneal grafts, where the doctors need to know how good they were seeing before and how good people can see afterwards with a correction. And that enables them to determine whether their surgery has been successful or not. So another big area, apart from refractions, for adults, it's mainly with pre and post-op cataract work and with corneal transplants, as I mentioned, but it's with children. So we see a lot of children who get referred with potential eyes that turn in, squints, and a lot of them need glasses. So we're able to prescribe them glasses using a technique called retinoscopy, which is where you use a special torch that you can shine into a child's eyes, and when you shine the light in their eyes, you see the reflection of the back of the eye. It's like an orange glow, and depending on how that reflection moves in the eye, you can put up a lens in front, a correcting lens that will neutralise or stop the movement. And when you've got that point where you've stopped the movement in either direction, that's equivalent to their spectacle prescription. So it's a very accurate way, an objective way of determining a child's spectacle prescription without them having to say a word.
And they don't have to fib if they can't see
That's
things,
right.
like when they go into eye test, if they don't want glasses,
Absolutely.
then you know what's going on really.
Yeah, so we do a lot of work with children, often put drops in their eyes to relax the focusing of the eyes to make it more accurate as well. When it comes to contact lenses in the call service, we're dealing with people who need contact lenses for medical reasons. So we tend to fit people for medical reasons where it might be to prevent or reduce pain in the eye. So some eye conditions are very painful, so if you put a contact lens in, like a bandage on the eye, it can make the eye much more comfortable. Say you've got interning eyelashes or a healing scratch on the surface of the eye. You can use it for mechanical support if someone's had a small laceration to the eye rather than putting sutures in. Occasionally you can use a lens even to deliver drugs and even to keep the eye moist using special lenses called Steele lenses that are hard shells that fit over the whole front of the eye.
How would you spell that? What?
Steele.
Yeah.
Yeah, S-C-L-E-R-A-L.
I've just not come across that word before, so I'm
Yeah.
curious to know what it was.
So the front of your eye is the cornea, is the clear window at the front, and then you've got the white of the eye, which is covered with the conjunctiva, and then the underlying white, or the main sort of fibrous tissue of the eye is the sclera. So you can sort of hold a reservoir of tears on the front surface of the eye, which can be quite useful for some patients. And also people who've got very distorted shaped corneas, and one of the big groups of patients that we see are patients called keratoconus, where they have, instead of having a dome-shaped front surface of the eye, the front surface of the eye becomes progressively more conical shaped, like a rugby ball shape, and this becomes increasingly difficult to correct with ordinary spectacles, so we can fit them with rigid contact lenses that artificially produce a smooth surface to the eye so they can see. And these patients, they've got no other way of being able to see clearly, and they're often young working group age. So it's really important that we see them in a timely way and we can keep them in work and able to drive and everything else that they need to do.
You've taken us through quite a few conditions already. Are there any others that we haven't already touched on, or is there something we're more commonly seeing?
Well, those in hospital work, those are the sort of areas that we specialise mostly in. The other area would be low vision work, where we're dealing with patients who've got poor vision for a variety of reasons. For example, macular degeneration, which is an age-related process. They may or may not be having treatment for that, which I can talk about later. And we provide them with what's called low visual aids, so LVAs for short. So this is a whole range of different magnifiers that come in different shapes and sizes. Some have lights, some don't, that patients can be trained to use to help them with the reading tasks and sometimes distance tasks as well, which can be a real lifesaver for some patients to keep their independence. That they rely quite heavily.
It is just a huge part of our lives, isn't it, being able to get around and see. And so you've mentioned a few kind of different jobs within your team as well. So who else is in the team in terms of their roles and what do they take care of? Because you've got some quite specialist colleagues, haven't you?
The work that hospital optometrists do is very, very different to, as I was mentioning before, what community practice involves. So if you think there's about 23,000 optometrists in the land registered with the General Optical Council, probably only about 10% work in the hospital. And the work that hospital optometrists, or hospital-based optometrists I should say, do is often more challenging because of the type of patients that we're dealing with, that often have comorbidity, quite complex. So I've sort of talked about the core service, but the other areas that we've become increasingly involved in over the last, with all my time here, which I've pride myself on the different roles that optometrists do here, is if you take any outpatient department in the hospital, the main 4 conditions that you come across most commonly would be cataracts, macular degeneration, medical retina conditions, glaucoma, and work in the emergency department. And I'm very proud to say that in this unit we've got optometrists embedded in all those different areas. So we have optometrists who've worked in the core service for many years and now have all done further exams. Like myself, I've done further qualifications to the master's level and above to do these things. And so we've got optometrists that deliver not just advanced care in cataracts or medical retina, but they also do certain what would be considered surgical things. Sorry, can I just say that again? It's not surgical, it's sort of techniques such as laser treatments.
Okay, let's hold on. Where should we go back to? Where did we start that little bit of a sentence? I can't remember. Do I need to ask the question again, or is that too much?
No, you can ask the question again.
Okay, so you've already mentioned some other team members. Do you want to talk us through what are the roles you have in your department and what they do?
Yeah, sure. So my role as the consultant head of department, obviously it's partly managerial, but my clinical role is for me now is developed from setting up the service initially, that is all those years ago, from the core service that I've talked about, and then moving into areas where I was working alongside consultants, seeing patients, and then saying, well, let's see if we can, what you're finding is in agreement with what we would find. So we audited results, we took sort of cohorts of patients and looked at what I thought was the outcome and what they thought, and then presented this at clinical governance within the trust and proved that yes, it was very good areas of agreement. And then it was sort of rolled from there that we were then moved into other areas of clinical practice, which at the time was groundbreaking. We started off with cataracts, seeing post-op cataracts for review, and then that developed into seeing assessments of new patient cataracts. And now we've developed, since COVID, we've taken a big role in emergency department, and medical retina is what now fills my working week.
And so to help that service run, who else works alongside you?
Yeah, so in my team I've got optometrists that have now been trained up and have now become embedded in other areas. The key main areas, as I mentioned, cataracts, glaucoma, emergency department, and medical retina. So they've taken on roles in cataract service, for example, seeing new patients and post-op reviews occasionally. In the medical retina service, which is what we spend most of the time doing, we're involved in reviewing medical retina, macular degeneration patients primarily. My particular role is in, and some of my colleagues would see vascular patients, which are people who've got diabetic retinopathy or have had vascular occlusions in the eye, like a stroke in the eye, which are treated with various things. I've got colleagues who work in the glaucoma team, where they don't just see patients in clinic for review, for monitoring and so on. They also are involved in, for example, laser treatments for their eye condition. To help, there's new laser treatments that help reduce the pressure in the eye, so they are offering that service. And we've got one optometrist who works in the emergency department, who's now what's called an advanced care practitioner, where she's sort of embedded with the doctors and nurses delivering care there. So it's quite a diverse range of roles. And
are you only based here in the hospital, or do you have clinics elsewhere as well? Because I know some of our services have clinics in different bases.
Yeah, so we're based primarily here in the Eye Infirmary, but we also work in peripheral clinics. For example, I work in Durham Treatment Centre. Some of my colleagues will work in other outreach areas. South Tyneside is another example, mainly doing children's clinics there. And interestingly, in this area, the diabetic eye screening service is actually run mostly by hospital optometrists here. It's not the case everywhere. So a lot of my team are involved in that. So they're based doing clinics in the community, even though the diabetic screening service is part of the Directorate of Ophthalmology now.
So you get out and about a little bit.
We do, yeah.
Very good. And so we are in one of your clinical rooms. Do you
Yes.
want to tell us, I mean, some of this looks a little bit familiar to me from opticians, but do you want to talk what kind of kit you use and what you need to do your job?
Yeah, so in the core service, I mentioned before about the importance of retinoscopy, which is a fantastic skill to have. Yes, you can go to the opticians and they might use what we call autorefractors, which is these fancy, wonderful bits of kit that can automatically tell you what prescription you need. That's great, but most of the patients that we see are not easy to get on these machines. So to be able to do retinoscopy is a really good skill. So that's something we tend to do on most of our patients. And then in front of me here is what's called a slit lamp biomicroscope, which is a machine that many people will be familiar with when they go to the optician, where you put your chin on the rest, and it's it is a big microscope, an illumination system and a magnifying system that enables you to view and examine the eye in great detail, up to sort of 40 times magnification if you need to, in 3 dimensions. So you've got 3D view at the front of the eye, and then using special lenses to help you focus onto the back of the eye, you can view the retina and the nerve and everything else. So if we're working in a contact lens environment, then it's important to monitor the shape of the cornea, and if there's any changes to what we call topography. So we've got computerized topography machines that we can use for that. But probably the biggest game changer in ophthalmology in the last 20 years or so is a technique called optical coherence tomography, or OCT for short, which is it works a bit like ultrasound. If people are familiar with, like, ladies going for an ultrasound on the tummy if they're pregnant or something, it works a bit like that, but uses light instead of sound, and you can use it. It's a painless, non-invasive way of shining these light waves into your eye, and you get these fantastically clear, high resolution, almost like histological cross sections of the back of the eye. So without those, it's very difficult to monitor many of the conditions that we now treat to know whether the treatment's working or not. So OCT is something we use regularly in medical retina clinics, increasingly in the glaucoma clinics, because now they're using this technology to monitor the optic nerve, which undergoes changes when you have glaucoma. That's a condition where you get damage to the optic nerve. Sometimes it's related to rise of pressure in the eye, but not always. And if you do have glaucoma, it's a condition that you don't necessarily know you've got until it's too late. So it's one of those conditions that when you go for an eye test at your optometrist in the community, they're always checking out for, to pick these things up early. So other ways of monitoring glaucoma is to measure the pressure, and there's ways of doing that with ways of actually making contact with the cornea, or other ways as well. And also with glaucoma, looking for visual field defects. So you tend to get a gradual loss of your visual field. So glaucoma is one of the conditions where, when in very advanced stages, you do truly go blind, in that you lose all your sight. Peripheral vision sort of gradually gets worse and worse until you're left with just a small patch in the middle, and then that ultimately will disappear without treatment. Whereas other conditions like macular degeneration only tend to affect the centre part of your vision, so it's when you're looking directly at things, it's the problem. And that's really important when you're talking to patients, actually, when they say, will I go blind? You can
That must be a really difficult conversation to have.
Particularly in medical retina clinics, you can reassure many of the patients that, well, they're not going to lose all their sight. Yes, it might be very frustrating that their central vision is poor, but overall, they're still going to have their peripheral vision intact.
So what does, because I've never seen an OCT machine, what does that look like?
It's not dissimilar to the machine here in front of you.
So what you might see in an optician's, it looks similar?
It's like, yes, like a big, sort of like an autorefractor type machine. Again, it's just a machine that you pop your chin on the rest, and it scans, it sort of shines lights into your eye, and that's basically it. There's one thing about ophthalmology, is that it's has lots and lots of toys. There's lots of different technologies, lots of different equipment. That's all very expensive as well.
Yeah. So what kind of kit? How has kit changed over the years? But also, how have the treatments that we're able to offer our patients, how they develop and how are they likely to develop in the future?
Yeah, so when I first came here, if we take, for example, medical retina clinics, when I first started working in those sort of almost 30 years ago, the mainstay of treatment then was laser. So just to explain why we do laser, if you've got diabetic retinopathy, obviously that affects your entire body, and people might be familiar with, having checks for their feet and so on, and other general health checks, but people maybe don't realise the devastating effects diabetes can have on your eyes. And the good thing about diabetes in a way is that all the eye changes that you can potentially suffer from if you're diabetic can be prevented if they're picked up early. So through screening, which is very good in this area, we can pick up cases where we are worried that they're going to develop eye-threatening problems. And this can come in two forms. It can either be through developing swelling in the centre of the vision, where you get leaky blood vessels leaking fluid into the middle part of your vision, what we call maculopathy, and that tends to affect younger patients as well as older patients. And the other concern is your body tries to grow new blood vessels, often in the wrong places. So if you get little tiny blood vessels growing, often from the optic nerve at the back of the eye, or sometimes anywhere in the retina, these have a nasty habit. If left untreated, they leak and they start to bleed. And then they bleed, the blood sort of seeps into the jelly in the eye, the vitreous, which ultimately can lead to the blood sort of contracting and pulling on the retina and causing a tractional detachment, so you're left with a blind eye. So what we try and do with laser is to make lots and lots of little tiny burns in the peripheral part of the retina to try and dampen down this inflammatory effect and to try and prevent these new vessels from growing, which works very well. Now the big game changer was with diabetic maculopathy, when in the past, if you tried to treat areas of leakage from a particular area where you thought there was a leaking blood vessel, that was fine, but if it was very close to the centre of your vision, you can't laser the centre because you potentially cause permanent damage to what's called the fovea. So the change there was the introduction of various drug treatments involving injections, which sounds horrible, but they're into the eye. So we probably do in the region of 23 to 24,000 injections a year in this hospital for patients with a variety of reasons, macular degeneration, and for diabetic retinopathy and maculopathy, and people, as I say, with vascular occlusions like strokes in the eye. And other treatments that have come along are using quite potent anti-inflammatory drugs called steroids. Mm-hmm. And instead of injecting like a liquid into the eye, these like little inserts that sort of injected into the eye that then dissolve, and over a period of a few months. So when I'm describing to patients, when they're sort of looking at me in horror that we're going to give them injections and trying to explain, well, why do I need these? Even in other conditions like macular degeneration, again, it's where you've got leaky blood vessels growing where they shouldn't be, normally in the centre of the vision, where they grow from underneath the retina, they sort of poke through and start leaking fluid and causing swelling, which causes distortion and reduced vision. It's not maybe totally accurate, but a lot of patients like the analogy. If I say to them, it's like being a gardener and you've got a perfect, pristine lawn, and then you suddenly get weeds growing on your lawn. So in that scenario, you might consider putting some weed killer on your lawn to get rid of the dandelions, leaving the grass intact. So in a similar way, we use these drugs which basically inhibit these little tiny blood vessels that are growing in the wrong places from developing, but leaving the healthy tissue hopefully intact. So that's been a game changer in that over the last 15 years it's become increasingly obvious after the treatment trials that came out. Many of them we were involved in here, showed how effective these treatments were. So it's kind of changed so much that we tend to use laser as a secondary treatment, whereas injection treatment is the mainstay of most of our treatments for medical retina patients.
I'm sure we do lots to make our patients feel comfortable and they're ready for that procedure. And I suppose it's a sign that people are more open to having laser treatment than they are to have injections. But I guess if it saves you sight and it keeps you going,
that's right.
That's
yeah. Most people.
Well, the best things offered for that patient's
Yes.
outcome.
Yeah. I mean, another big change is with glaucoma, where up until relatively recently, the mainstay of treatment would be using drops. So if you thought that someone you were worried they were developing glaucoma, or they had glaucoma and you wanted to try and control its progression, then you'd put them on various types of drops that lower the pressure in the eye by different means. But a big game changer was a study that showed that using a special type of laser, which you apply to the front part of the eye, what's called the trabecular meshwork, this can help through a combination of chemical reactions and so on. You can actually improve the drainage of the fluid out of the eye through what's called the anterior chamber angle. And this has been shown that if you apply this laser treatment in the early stages to selected patients, then they don't need drops at all. They can go for several years without drops. And I'm proud to say that we've got one of our optometrists trained to deliver that laser treatment here at the Eye Infirmary.
And are we using AI at all? Because I know that obviously we're very active in research in this hospital. Is AI playing a part in this, or am I getting a bit confused?
At the moment, it's definitely coming, and it will have a big impact. That would be my prediction in the next 10, 15 years, most certainly. I know some of my colleagues are directly involved in AI for looking at feature recognition in things like diabetic retinopathy, for example. But I think it's only a matter of time before that does come, where they're going to have software that can, for example, take a photograph of the back of an eye of somebody with diabetic retinopathy and be able to grade it without necessarily somebody having to look at it as well. So AI is creeping in all sorts of different ways, and certainly looking at building algorithms to treat patients where they can number crunch vast amounts of data to come up with chains or nuanced treatments for people based on all that information that's been analysed, which takes a lot less time than as humans did it.
And I know we've been doing some work with AI, I'll speak up because the heating system's introduced itself again. We've been using AI to look at, because you don't necessarily know how a patient is going to react, their outcome is going to be. Just because you add these things up at the start doesn't mean you get this answer at the end. So I guess that might help change the path of whatever we do.
Yes, I mean, it's definitely going to have an impact. I mean, the main driving force for change in clinical practice is being able to know whether a treatment is safe or not, and no one should be using drugs that we think are not safe, or we don't know what the long-term outcome is. So unless we've had treatments that have gone through treatment trials, we have to be very careful if we're using anything what we call off-licence. So being part of the unit here, which is one of the largest eye units in the country, and having such a sort of national profile for research, it's good to know that you're involved in all these new developments. And again, the optometrists are involved in the clinical research trials, where they have a key role in providing a lot of the refractive data, which is essential for determining whether these different treatments that we're trialling are going to be effective or not.
More to come. Now, we're going to be moving to a new hospital in a couple of years. So how have you been involved in those discussions? What differences are going to make to you and the team? Because, you're kind of in an office behind an office, and I presume your setup's going to be totally different.
Yeah, so it's been an exciting time, and I've been personally involved from the very beginning, along with lots of people here. That's one thing I would say, that the whole hospital has been involved to varying degrees. So it's going to be our hospital, which is really good. So even going back to a few years ago, when we were looking at how we could redesign the Eye Infirmary to rejig it, we had what's called a Kaizen event then a few years ago, and then it's nice to see that a good few of the ideas that sprung from that, where we realised it wasn't going to be possible to make things work effectively in this hospital any longer, was all that service design has gone into this new hospital, which instead of having, for example, in the medical retina clinics, which have just expanded so much that they're sort of popping up in every part of the hospital where there's a clinical space, but all the patients still have to go back down to the medical photography for all these investigations. So in the new hospital, it's been purposely designed so that each sort of area or clinical domain has its own dedicated area with its own pathways where patients will flow through much more effectively and efficiently. So it's a good thing because in the years to come we're going to have a lot more patients to see. It's a good thing that we're all living longer than we were 20, 30 years ago. And although I think the latest figures are that we're in the world, I think people are living about 19 years longer than they used to do 30 years ago. Sadly, we're all living longer, but with lots of comorbidity, so they're not necessarily happy years. So we're going to have to find ways of how we're going to treat and manage all these people. And that's a key thing, in that we've got a new hospital, and the optometry department will be similar size footprint to what we have now. So we'll still be able to provide all our core services that we're asked to do, but most importantly we're going to have optometrists working in all the other key areas in the hospital, and even with the best will in the world, the numbers of patients means that we won't be able to see them all within the new hospital. We're going to be looking at having to share some of the work with community colleagues. I know that's a lot of work going on with that at the moment, and just recently the Royal College of Ophthalmologists and the College of Optometrists have updated a vision statement on how the two professions will work together much more closely to ensure that optometrists are promoted as the first point of contact for patients, and that where it's safe to do so, you can select cohorts of patients of fairly low risk that can be hopefully shifted from a hospital setting into community, so they can be managed effectively closer to home. Patients like that, they don't have to travel so far, there's no worries about parking, they can be seen closer to home. But this all comes back to technology, and it's how the sort of digital communication between the hospital setting and community care, which we're getting there, but there's still a bit of a way to go. But that's the future, I think, is sharing a lot of the work where we can with the community, and we've got this massive workforce of optometrists in the community that could be utilised much more effectively, and I think whichever way you look at it, we don't have enough doctors, and in the next few years we're not likely to have enough doctors to keep up with the burgeoning demands, particularly in ophthalmology. So we're having to look at other ways of utilising other healthcare professionals, and I'm not just saying optometrists, it can be nurses, orthoptists, medical photographers. They've all got their roles they can play.
Because when we look into the years ahead, are you looking to recruit new members? I mean, all departments kind of have people moving on and coming in, but do you have a bit of a vision of how you need to boost your numbers?
Yes, I think we're in a sort of victims of our own success at the moment, in that having demonstrated conclusively that we can provide a lot of services in these what were traditionally considered doctors' roles. Obviously we're not doctors, but we're able to undertake a considerable amount of clinical caseload that would have otherwise been done just by doctors. So we've got to really think about how we can expand the workforce in order to take on more of these roles. So we've got to sort of think of terms of, yes, there's always the core service, which is where we're doing the refractions and so on for specialist cases, but there's so many more things that we could still, even now, potentially move into to help get the numbers down. It may be that, with certain services move entirely into the community. Another area is the independent sector as well, which I think, like it or not, is here to stay. So we've got different ways of getting patients seen effectively and on time. We can't possibly do it all ourselves, we need help from outside, and we have to accept the help that's provided by the independent sector as well, so the private clinics.
And so that's kind of, we have to work alongside those as well as our
Absolutely.
community colleagues. Because if you were kind of, a lot of people will be listening to this who might be interested in this as a career, but also maybe interested in coming to work for us. What would you say to the people if they were interested in joining our team? What would you say is the real selling point of our hospital as a place and a career, a place where you can develop your career?
Yeah. Well, the thing I've loved about working here all these years is that feeling of being at the forefront and at the cutting edge of what's available. And certainly in my profession as an optometrist, I sort of feel proud to say that I've helped push forward what optometrists are able to do safely, with the right training and support, what extra things we could do in future. I think working in a big hospital like this, you've got the camaraderie of working with a multidisciplinary team, which I enjoy, because you learn a lot from other professions. But also, my passion has been, along with the clinical side of things, and actually just sitting talking to patients and just helping them to explain why they're here and what treatments they need and so on. It's about education. And so I've been involved in the last 10 years in national things, for example, looking at developing the medical retina postgraduate qualifications for the College of Optometrists, or I've been involved as well in the master's degree for the advanced care practitioners, which is run down in Moorfields and University College London. So seeing those young optometrists, I'm a bit old to do all these things now, but the opportunities they have now for the training that they can get to develop them into these new roles which are right for the picking, I think that's really exciting. So even in community, the push for optometrists to undertake postgraduate qualifications is really sort of gaining momentum now. Specsavers, for example, are employing or encouraging a large cohort of their optometrists to become independent prescribers. So most of my staff here are independent prescribers, and there's lots of advantage of that being in a hospital setting. And that means that as optometrists, we can prescribe a very wide range of drugs, antibiotics, steroids, and so on, for quite a wide range of clinical conditions, which means that we can independently manage a lot of these things, which is in support of the doctors, who can then concentrate on the more complicated things.
And we also here in the North East, and I think it's North Cumbria as well, run Find Your Place, which we're part of a bigger network of trusts and organisations. So if anybody's interested who doesn't already live in the North East, you can have a search for that, and it gives loads of information for if you want to be doctor, nurse, dentist. There's loads of information about why the North East is a really good place to base your career. But as somebody who's not originally from the North East, what do you love about being here in the region?
I love the North East because it's the countryside, it's the people. It's not quite as busy and frenetic as when I used to live down in London. And I think we're really, really lucky in the North East compared to just about any other region in the land, where you've got hospitals with all the top specialties. So no matter whatever's wrong with you, or if you're unfortunate enough to have a terrible accident, we've got all the specialist care practically here on our doorstep. And we've got that expertise, which is probably second to none in some ways, as good as anywhere you can get, even in special hospitals in London. So having that sort of background and that support, there's so many opportunities for optometry in this region, and I think with all the advantages of having not such a busy commute to work and that sort of thing, there's lots of advantages living in the North East.
Yeah. There's always things to do. Sometimes you have to go a little bit further to find them, but then you pick something up along the way, don't you? And we are going to have this, as much as we love our hospital building here, and it's a fantastic, all these services that work together, and it's a brilliant kind of bigger family, we're going to have a new hospital that people can come work in, and that's not going to be something you'll see in a lot of places, especially in this area as well.
No.
In this area of specialism.
Yes. But I think, as I was alluding to, we'll hopefully have bigger connections with in education, for example, we're looking at developing links with local universities. That's like, for example, North Tees or Teesside University, where they have an optometry course. We're hoping to be able to have students in their sort of final year at least coming here for clinical placements. We've run pre-registration training courses here for many years, and it took a bit of a hit during the COVID period, but we're trying to get back on track with that. And this is a way of improving our profile and getting the youngsters coming into the profession thinking, this would be a nice place to work, this would be an interesting place to work. And it's just so full of opportunity. Clinically, we're involved in so many different clinical areas, and there's the opportunity to be involved in research, and that's something else, not just within the clinical trials within the hospital. I'm quite keen to see optometry in its own right taking a greater role within community optometry as well, and see if we can work towards sort of greater research input from community optometrists.
And so what do you love most about your job? And what would you say to somebody who's starting out, your words of wisdom, if you were to give some advice to somebody who's thinking about this as a career, or, you know, even a change, I guess?
Yeah, no, I think optometry is a fantastic profession to come into. Some people might think, oh, well, maybe I'd prefer to be a doctor, and that's fine. In fact, there are a lot of optometrists who've then gone on to do medicine, and some of my consultant colleagues now started life as optometrists. So there's so many opportunities for you to develop your clinical skills, and I think you've just got to sort of take the opportunity of going for those. So I'm losing it here.
No, I'll ask you. So I'll say. Well, I'll tell you what. We'll divide it into two. So, what do you love most about your job?
Yeah.
So I'll ask you. I'll take a deep breath. What do you love most about your job?
The thing I love most about my job is the contact with patients and the feeling that you're making a difference to their lives and ensuring that they can see as well as they possibly can, depending on what eye condition they may have. It's about working as part of a large multidisciplinary team, that camaraderie I mentioned before, and it's about being at the cutting edge of new developments and being involved in sort of pushing the profession forwards. And this hospital has given myself personally and my team a lot of opportunities to do that over the years. So we're quite fortunate, and a lot of the things that we do here are quite different to elsewhere. And a lot of the things that maybe get high press elsewhere in different hospitals, a lot of things we started here in the beginning, and other people have sort of taken things and run with it. And it's great to see that across the country now we've got optometrists in hospital work, I'm talking, involved in so many different aspects of clinical care.
And I didn't realise, because I know that I assumed you looked after adults, but I didn't realise you had such a hand in young children. It must be really satisfying to know that you've set them up for a future that involves eyesight that is much better than they would have had otherwise.
Yes. So going back to when I first came here, there were no real children's refraction service as such, and that's something I sort of proudly set up with the then head orthoptist, and we set up a children's refraction service across the patch, South Tyneside, sort of North Sunderland, South Sunderland, where we covered even the special schools back in those days. So we were going into various special schools, seeing children with lots of different learning challenges, and that was really interesting. And we still are involved to an extent with that work. Now things have changed and it's provided in different ways, but the children is in the core service is part of the main reason the optometrists like working here, because the small children are such fun to work with.
I imagine it's a different kind of
completely different
day.
Yeah, I mean now I work, as I mentioned before, almost exclusively in the medical retina service and partly in glaucoma and cataracts. So in the past I used to work a lot with the children, and now my colleagues are doing that, and it's challenging work. Often, we have children come here that need contact lenses, for example, from a very young age, even babies that are fitted with lenses on occasion, and that can be challenging to keep the parents on board with taking the lenses in and out on a daily basis and so on.
Oh, I hadn't even thought about that aspect of it. I thought you were just going to leave them in for a bit.
Yeah, you can, preferably if they can be removed.
Yeah, that must be
regularly,
quite a big ask for a parent.
Disinfection, yeah. So, yeah, the key thing about children is it's so important that they're given the opportunity to see as well as they possibly can. And that when you read in the press at the moment, there's lots of pressure around children's services generally, and long waiting lists for children to be seen in the health service. And I think that's something that is really important, because if a child, it could affect their whole lives. If they're not able to see, it could affect their career prospects, whole lives ahead of them. So I think it's really important that we prioritise the children and make sure that we give them the best chance to see as well as they can.
And if you were to give a few words of wisdom to somebody who's setting out on the career, look, this is something you're interested in, what kind of tips or information would you give them to set them off on the right path?
I think if you're really keen, like we've had in the past, I'll give you a good example of a young lady that came to us at 16 who expressed an interest in doing work experience, and she thought she'd like to go into something in the health service, wasn't really quite sure, maybe medicine, and so on. Yes, we'll take you for a placement here, and she loved it. And then she decided that she would not do medicine, she would pursue an optometry degree, which she duly did. And then she went on to do a pre-reg in Leeds in a hospital setting, and then decided to move back to the North East where her family's from. And now, after having worked in the core service here for a number of years, she's now an advanced care practitioner in the emergency department. So I think if people are willing to come and find out what is possible, we're willing to take people, if they want to just come and have a look round, come and see what we do. And we often take placements, not just for pre-regs or work experience, we take placements for people doing their independent prescribing, who are doing it in practice, who need their hospital placements to sort of finish their logbooks. But when they come and see actually what's going on, they think this is a really good environment to work in. There's a lot to learn, it's challenging, sometimes a bit scary, you sometimes feel a little bit out of your depth, but with the right support from your colleagues, it's a good environment to work in.
It is a good place to be.
Yeah.
It is a good place.
Yeah.
So Chris, thank you too, and also to the plumbing system for joining us.
Thank you very much.
You.
Thanks for joining us for this episode of our People podcast. We hope you enjoyed it, and check out our other stories. Hit subscribe to keep up to date with the latest, and catch up with what we've been up to on our Twitter, Facebook and Instagram pages. Just search for our name.